Hello my friends, welcome back to Cardiac Academy. Today we continue our video series on point of care echocardiography. In our first video we talked about the parasternal long axis view, so today it's all about the subxiphoid view and the IVC. This is an important view, so let's get started. Alright, let's talk about the subxiphoid view. So in this slide we have again a summary of all the most important views that we can see on point of care echocardiography. So on the last video, we actually talked about the parasternal long axis view. So today we're gonna focus on the subxiphoid view, okay? This one right here. And I always say to everyone that wants to learn point of care echocardiography, and it's not necessarily going to cardiology, that if you're gonna learn these two, okay? All right, let's continue. All right, so as always, patient positioning and probe positioning is important. So on the parasternal long axis view, we said that the patient should be lying on their left side with their left arm behind their head. In this case, for the subxiphoid view and the IVC, you actually want the patient to be lying flat on the bed, okay? Once you have the patient lying flat on the bed, you can ask them to bend their knees. That's gonna relax all the abdominal muscles, and it's gonna be easier for you to apply pressure, because on the subxiphoid view, you actually have to apply some pressure to the abdomen, okay? So have your patient supine, ask them to bend their knees, and you can also ask them to take a deep breath. Remember that when you take a deep breath, your diaphragm will go down, which will approach your heart closer to the probe, okay? All right, so once you do that, you're gonna look for 2 to 3 centimeters below the subxiphoid view, and you're gonna divide the patient's chest in two, right? You're gonna right hemidiaphragm and the left hemidiaphragm. So once you do that, your probe should be localized closer to the more to the right side. If you look here, so you can see how the probe is more towards the right side of the patient. However, it's gonna be looking towards the left side of the heart, okay? So first, you're gonna divide the abdomen in a right and left hemidiaphragm. You're gonna put your probe more toward the right side of the patient, and then the probe should look slightly towards the left of the patient, okay? Remember that each probe will have a probe marker or an indicator, which we see here. So that probe indicator should be looking towards the left, as if you divide the patient's abdomen into a clock, it should be at 3 o'clock, just like we see here, okay? And once you do that, your probe should be almost flat, okay? Contrary to what we've seen before, it should be almost flat, okay? And you're gonna see that depending on how flat you are, you might see the aortic valve. So if you see the aortic valve, you are too flat. You need to increase the angle of the probe, just like we see here. You see how the probe can be flat, but you can also kind of increase and decrease the angle. If you see the valve, try decreasing or increasing the angle, I should say, of the probe, and you can also rotate slightly counterclockwise, okay? And that's gonna make that go away, okay? When you see the aortic valve is almost like a 5-chamber view, but we're looking for the subxiphoid view, okay? So the aortic valve should not be there. We shouldn't see it, okay? So now reviewing a little bit about anatomy, you're gonna see that this view almost looks exactly as a apical 4-chamber view, which we're gonna discuss in a future video. The difference is that you're gonna see the liver, okay? So you can see here, all of this structure is the liver. And then below that, you see the heart, okay? I'm gonna put it in blue or purple. I'm colorblind, by the way. So not entirely sure whether this is blue or purple, but it's different than red, okay? So you see the liver in red, and then in blue or purple, you see the heart, okay? So you're also gonna see that the left chamber, the left ventricle, should look bigger than the right ventricle, okay? So your right ventricle should not be more than 2/3 the size of the left ventricle. And you're also gonna notice that it has like a different shape. One is more triangular, just like you see here. So you can see how it's more triangular. You can also see it here, more triangular in shape compared to the left ventricle, which is more rounded, right? And you can see that here as well. This is normal. This is what you expect to see, okay? And then the left atrium and the right atrium should be the same size, okay? You can see here how the right atrium and the left atrium look the same size in this particular view, okay? All right, let's move forward. All right, let's talk about the McConnell sign in pulmonary embolism. So in pulmonary embolism, there's a sudden increase in the pulmonary artery pressure, which causes the right ventricle and the right atrium to become dilated, okay? You're gonna notice also that the left ventricle will become hyperdynamic. So the McConnell sign refers to a presence of a transition hinge, which you can see at the apex. In this particular image, it's not the best one to see it, but we'll see a different example. And you're also gonna see that the right ventricular wall becomes hypokinetic, okay? Like in this image right here. While keeping the apex beating or contracting, okay? Let's look at a better example. So in this view, it's actually an apical four-chamber view, but it better demonstrates the McConnell sign, okay? So let's go over it, okay? So first, the right ventricle and the right atrium are gonna be dilated. And we previously said that the right ventricle should not be more than 2/3 the size of the left ventricle, right? And you can see here how dilated it actually is. I'm gonna just trace it for you. You see that compared to the left ventricle, it's bigger, okay? Let's just highlight that for you as well. So this is the left ventricle, very hyperdynamic. And then the right ventricle, if you look at the right ventricular wall, it's actually hypokinetic. You can see it's actually not contracting too much. But look at the apex. If you look at the apex, you're gonna notice that it actually is contracting. You can see here the McConnell sign. This happens because even though there's increased pressures in the right ventricle, the left ventricle is still strong enough to make the apex contract, okay? So that's why you see an enlarged right ventricle with hypokinesis of the right free ventricular wall with contraction at the apex, okay? This is known as the McConnell sign, and it's associated with pulmonary embolism, okay? In fact, the McConnell sign has a 77% sensitivity for a pulmonary embolism and a 94% specificity, okay? However, you can also see the McConnell sign in other pathologies such as ARDS, right ventricular infarction, and chronic cor pulmonale with an acute stress, all right? Very good. Okay, so the subxiphoid view is also useful to assess contractility. You can see here in the first example how a good contractility should look like. You can see that left ventricle contracting. All the walls are approaching each other. Like we said on the parasternal lung axis view video that they should. It's getting closer. However, compare that to the second example, and you can see how these walls are not approaching each other. So that's a very poor ejection fraction, a poor contractility, okay? And we can also look for pericardial effusions, okay? In this case, you can actually see how comparing the blood inside the left ventricle here, you see how anechoic it is. Compare that to here, it's more echogenic. So in this example, it's not only a pericardial effusion, but it can also actually be like hemopericardium is like old blood. So new blood is like anechoic. Old blood becomes more echogenic as the blood clots, okay? So you can also see here in this example, so what do you think what's going on here? So you can see that there's some fluids or fluid of some sort here, but in fact it's not fluid, okay? It's actually a fat pad, okay? So remember that around the heart we can also have some fat, and when that fat becomes big enough, it might look like a pericardial effusion, but it actually has some, it's speckled. It has some like tiny hyperechoic structures that lets you know that it's actually fat. So it's a fat pad, okay? An epicardial fat, you can see here. All right, it might confuse you for a pericardial effusion, but as you gain more experience, you will be able to differentiate them. A pericardial effusion should be anechoic, fluid around the heart. If it is more echoic, it could be hemopericardium, but if it looks like more speckled in appearance, it could be a fat pad, okay? Very good. All right, let's look at this image now. Is this only an effusion? So what are the key findings on tamponade, okay? So you're gonna see right ventricular compression, which we're seeing right here, okay? So you can see how comparing this right ventricular wall to this one right here, you can see that over here it's just a pericardial effusion, but in this one over here, there's more right ventricular compression, so this is more consistent with tamponade. Now remember that tamponade is a clinical diagnosis, okay? It's not, the imaging can help with the diagnosis, but it's a clinical diagnosis. Usually, what do you see on tamponade? You see Beck's triad, right? So Beck's triad, what is Beck's triad? Hypotension, muffled heart sounds, and JVD. But you can also see tachycardia and pulsus paradoxus, okay? All right. Another important thing to remember about pulmonary embolisms is that because of that increased pressure in the right ventricle and right atrium, that pressure is also going to be transferred into the IVC, which is another finding. You will see that the IVC is dilated, which is the next thing we're going to get into now. All right, so the inferior vena cava. So in the subxiphoid view, we can also access the inferior vena cava, the IVC. Okay, this allows us to assess volume status, but also can help us identify increased right ventricular pressure and right atrial pressures. Okay, it's very easy to confuse the aorta for the IVC because they're because they're next to each other, so close to each other. So we need to use appropriate technique for that not to happen. All right. So as you can see here, we have the IVC right here, number 1, and then next to it we have the aorta, number 2, and you can see how they resemble each other. But there are a few things we can look for to tell them apart. So one thing is that the IVC is very thin walled compared to the aorta, which is gonna have thicker walls. You can see here how the IVC very thin, and the walls are non-parallel. You can see how they're curved. Compare that to the aorta, which you can see how much more thicker the walls are, and they are parallel, okay? Another important thing is that the IVC, because it's very compliant, is gonna decrease its caliber with the respiratory cycle. Compared with the aorta, that shouldn't happen, okay? So the aorta is gonna be pulsatile. You can see that here, but it does not collapse. Now look at the IVC right here. It collapses each time you take a breath, okay? All right, so how do we access the IVC? So for us to make sure that we don't confuse the aorta for the inferior vena cava, the best way to do it is to first start looking for the subxiphoid view. And once you identify the right atrium, then with appropriate technique, you can actually see the IVC connecting to the right atria. So this is the way we do it. So first, find the subxiphoid view, just like we discussed earlier. Number one, you're gonna look for the subxiphoid view. You're gonna put your probe slightly towards the right of the patient, and then you're gonna point your probe slightly towards the left, and the probe marker should be looking towards 3 o'clock, just like we see here. After that, you're gonna start rotating your probe upwards. And what I mean by that is that, remember, there's a probe marker. We have it right here. So that probe marker at first is gonna be looking towards 3 o'clock, just like on the first image. In image number 2, you're gonna see that by rotating the probe counterclockwise, that marker is actually gonna end up looking towards the ceiling. So just like on image number 3, you find your location, you start rotating, and then the probe marker is gonna look upwards, okay? And by doing so, you're gonna see how the IVC comes into view. So if you look here, you see how the atria is in view right here, and then the IVC comes in, okay? Just by doing that rotation. So again, you find the subxiphoid view. Once you're there, start rotating the probe, and slowly you're gonna see the IVC coming into view, okay? And that way, you're actually seeing the IVC connecting to the right atrium, and there's no way you can confuse the aorta following these steps, okay? All right, so let's just look a little bit of the anatomy. So we have the right atria right here. Then we see the IVC connecting into the right atria. We see the liver as well on each side of the IVC. And we can also look at the hepatic vein right here. There it is. So, which is another important anatomical landmark that we need to look for, okay? All right, now that we know what to look for, let's continue. Okay, so when you look at the IVC, one of the things you're looking for is for fluid status, okay? And the way we assess for fluid status is by looking on how much does the IVC collapses, okay? So an important thing is that we need to look in the appropriate location, okay? So the IVC, pretty long structure, right? Where do we look? We look 2 to 3 centimeters from the atria, okay? So right where the arrow is. Because if you look a little bit more distal, the collapsibility of the IVC is going to be exaggerated, okay? So it has to be 2 to 3 centimeters from the atrial junction, okay? Otherwise, you're not measuring the correct place and you might make mistakes, okay? All right, so the collapsibility index. So the collapsibility index is how much is the IVC collapsing, okay? And we can measure this in 2 ways. We can do it visually, which is the way we're gonna concentrate on this video, but you can also use M mode. The benefit of M mode is that you are actually measuring, you're looking for a number, versus visually, you're kind of estimating how much is collapsing, okay? But both of them are pretty useful. Using M mode, you can see here how you can measure when the patient is doing expiration in the respiratory cycle, and then you can measure again when the patient is inhaling, is inspirating during the respiratory cycle, and that's going to give you 2 numbers, and then you can calculate the collapsibility index. And we can see that here. So remember that when we breathe, we decrease intrathoracic pressure, okay? When that happens, the preload goes from the IVC into the right atrium because you have decreased intrathoracic pressure. That makes blood getting to the atria much more easier. And then when you expire, that intrathoracic pressure comes back to normal, which makes the IVC dilate again. And that's exactly what we're looking for here. So here on M mode, you can see during expiration, it's gonna be wider. then you take a deep breath, intrathoracic pressure decreases, preload from the IVC into the atria, collapses the IVC like we see here, and then you get the two numbers. You have a maximum dilation, which you have right here, and then you have a minimum dilation. And this is the formula that we follow. So we're gonna take the maximum dilation during expiration. We're gonna subtract that from the minimum dilation, and then you divide by the maximum dilation again and multiply by 100, okay? So in this particular case, you're seeing how during maximum dilation, it measures 23.7 millimeters, and then minimum is 13.97 millimeters. Plugging the numbers into the formula, and it gives you 0.41, so 41%, and that's your collapsibility index, okay? In this case, that means that the IVC is full. It means that the IVC is collapsing less than 50%, which is the magic number, which we're gonna see right now, okay? Okay, let's talk numbers. So when we assess the IVC will normally measure 2 centimeters, okay? In this particular table, we have 2.1 centimeters, but 2 centimeters is like the average, okay? So remember that right here, this is a caliper. So this allows us to measure. So each of these measure 1 centimeters. So a normal IVC should have like no more than 2 dots, okay? So that's the first step. You're gonna look at the IVC, and you're gonna see whether it measures more than 2 centimeters, okay? And depending on how much the IVC is collapsing, that's gonna approximate the central venous pressure of this patient, okay? So we have that in this corner right here, okay? So let's say you have a patient and the IVC measures more than 2 centimeters and is collapsing less than 50%. You can imagine it's big and it's collapsing less than 50%. That's a full IVC, right? Is the approximate right atrial pressure is 15 millimeters. That's millimeters of mercury. That's a full IVC. Now, in the other hand, let's say that the IVC normally measures 2 centimeters. It's measuring less than 2 centimeters and is collapsing more than 50%. Then we're right here. That's a empty IVC, and it's around 3 millimeters of mercury. So I think that's probably the best way to remember it. The extremes, when it's a full IVC and when it's an empty IVC, because as you see, in the middle is normal. Remember that the normal central venous pressure is from 8 to 12. So anything in between will be normal, okay? All right, so just like we said, the extremes, full IVC more than 2 centimeters, collapsing less than 50%, that's a full IVC. Less than 2 centimeters, collapsing more than 50%, that's an empty IVC. Everything in the middle is normal, okay? All right, so just like we said, we just discussed this. Let's get into other signs of full IVC or signs of congestion, okay? So looking at the hepatic veins, which connect to the IVC, can also be very helpful. So when you have a full IVC, all that pressure is going to be transferred into the hepatic vein as well. And a lot of echocardiographers will compare dilated hepatic veins to either a moose, which you can see right here, and it kind of looks like a moose, or they also compare it to the Playboy bunny, which also looks like the Playboy bunny. So if you find any of these two findings, then that's a sign of a full IVC, okay? Either the moose or the Playboy bunny, okay? So let's practice, okay? So let's take a look at this IVC. So the first step is look for the right atrium. The right atrium is around here. And we have to remember where to measure, okay? It has to be 2 to 3 centimeters from the atrial junction, right, with the IVC, right? It should be around here, more or less. Why there? Look at this corner right here. You can see how exaggerated that IVC collapses. So let's say that you measured here in number 1 instead of number 2, you're gonna have a big difference in how much the IVC is collapsing. Okay, so let's look at number 2. So remember, these are calipers. So it's each of them represent 1 centimeter. So it's measuring slightly less than 2 centimeters. So we're here. And it's collapsing less than 50%. So we're here. So that's a normal IVC, normal pressure. So it's within normal limits, right? So that's what we meant. Look here, not here, and that will give you a normal pressure, okay? Now, second example, again, this is the atria right here. Look, 2 to 3 centimeters from the junction, around here. Look at the caliper. So that's obviously measuring more than 2 centimeters, right? So we're here. And it's collapsing less than 50%, right? So we're here. So that gives us a full IVC. And in fact, if you look closely, you can actually see the moose as well. So we have dilation of the hepatic veins as well, okay? So this is a full IVC. Now let's take a look at this last example, okay? So again, here's where the atria is. Look, 2 to 3 centimeters, so just where the caliper is. Measure is measuring, I would say, slightly less than 2 centimeters. So we're here. And it's collapsing more than 50%. So we're here. That's an empty IVC, okay? You see, bulletproof. Pretty easy if you follow the steps, okay? All right. Now that we talked about the collapsibility index, we need to be aware of the limitations of the collapsibility index. So anything that increases intrathoracic pressure will affect the collapsibility index, meaning positive pressure ventilation, okay? So if your patient is intubated or is on BiPAP or CPAP, then the collapsibility index is not gonna be the best way to measure the IVC, the pressure or the volume of the patient, okay? In that case, we need to use what is called the Distensibility Index, okay? So it's similar but different, okay? So again, for the Distensibility Index, N mode is gonna be the way to go, okay? Because you need to really measure. And you're gonna look for the same numbers. You're gonna look for a maximum dilation and for a minimal dilation. The difference is that in this case, the formula is a little bit different. It's maximum minus the minimum and then divide by the minimum, which is different than the collapsibility index in which you divide by the maximum, okay? And in this case, the magic number is 18, okay? So if the distensibility index is more than 18%, then your patient is fluid responsive, okay? If it is less than 80%, then they're not fluid responsive, okay? And this is especially gonna be useful on intubated patients, septic patients that you need to check whether they're adequately fluid resuscitated before adding pressors, okay? So it's very similar but different. Non-ventilated patients, you're gonna do the collapsibility index. You're gonna use the maximum dilation minus the minimum dilation divided by the maximum dilation. That's gonna give you a collapsibility index. In this case, this patient on the left, it's adequately resuscitated. You don't need to give more fluids. Now, let's suppose that this same patient with these same numbers is now intubated, has positive pressure. So you're gonna use the distensibility index. Again, you're gonna take the maximum minus the minimum, but this time around, you're gonna divide by the minimum. And it gives you a distensibility index of 70%. So more than 18%. So in this case, this patient actually is fluid responsive. So that's why it's so important to use the appropriate calculation for the appropriate patient. Because depending on whether the patient is ventilated or not ventilated is gonna be either fluid responsive versus non-fluid responsive, okay? So just keep that in mind, all right? All right, my friends, that's it for today. I know this has been a long video, but it's an extremely important and useful topic. I hope you liked it. Please share, like, and subscribe to our channel. And as always, I'll see you at the Cardiac Academy.